Hello. Chapter 20 on the older adult presents information on frailty, when to screen older adults, immunizations, and cancer screening, the spectrum of cognitive decline and dementia screening tests, and a new algorithm for fall prevention from the CDC. I've actually broken this lecture into two parts so that I won't be rushed through the important priorities. This is one of the few times that I review anatomy and physiology with you because they're unique to the elderly population. So the first thing I need to do is correct this slide's information and let you know that the current number is over 43 million in the United States of older adults, and it's expected to reach 80 million by 2040, which would be over 20% of the population in the United States. Lifespan at birth is age 81 for women and age 76 for men, and Americans over 85 are projected to double from 6 million, which was counted in 2013, to over 14 million in 2040. It's important for us to look at demographics and discuss this demographic goal of not to increase lifespan, but to increase health span of the older population. And that we really are, we want to maintain full function and allow our older patients to live active lives in their homes and communities. Frailties is a common myth, though. About 95% of Americans over 65 live in community, and only 5% reside in long-term facilities. When we are assessing the older adult, though, there are some unique aspects of assessment. We need to think differently from a disease-oriented approach of history taking that we do in physical exam of the younger patient to focus on the healthier, successful aging. And you've got to also correlate family, social, community supports and what's available to that patient. You have got to direct that assessment to include a comprehensive functional assessment, and there are many opportunities promoting older adults' long-term health and safety, and this is the opportune time to do that. So let's do some anatomy and physiology review that reflects primary aging that occur over time. And we're talking about independent of changes induced by disease, just the normal aging. When you see elderly adult that is healthful, what you will see is the discrepancies such as when stress such as dehydration, shock, or acute illness occur, then that makes them more liable for issues. The aging population really displays heterogeneity, which talks about diversity. Well, and we've got to consider, so in this diverse population, the usual aging versus successful aging, and what accounts for that? I like the statistic at the bottom of the page, and I found this to be true, that individuals who escape onset of debilitating disease entirely live healthy lives into their 80s and 90s, and some centurions. So blood pressure. We know in Western societies that systolic blood pressure tends to rise with aging, and that's due to the aorta and large arteries stiffening and becoming atherosclerotic. That makes that aorta less distensible, and given a stroke volume, causes a greater rise in the systolic blood pressure, hence systolic hypertension, with a widened pulse pressure. But diastolic blood pressure stops rising at approximately the 6th decade. So as an extreme comparison, many older adults develop orthostatic hypotension, so they have a sudden drop of blood pressure when they stand. Heart rhythm and rate tends to, the pacemaker cells tend to decline. Those are those cells at the SA node, and that does affect response to physiologic stress. So they're more likely to have abnormal heart rhythms, such as atrial or ventricle ectopy. Respirations is generally unchanged, and temperature is less regulated, making the elderly person more susceptible to hypothermia. Skin, nails, and hair. Perhaps this is one of the areas in anatomy we're the most familiar with. What comes forward in our reading and information for me is that related to the nails, we do also have to consider the implications of blood flow and arterial and vascular supply, and the effects that they might have on the nails. We all know that hair loses pigment, the melanin, and hairlines recede. So we also have to consider that hair totality also reduces, and that's pretty normal in most patients. But listen, a consideration that's vital for us is that many changes that are common in that lighter skinned patient, it might not apply at all to people with skin of color or darker skin tones. And that is when you must research and understand what is the norm for that patient and related to skin coloring or their ethnicity. Head and neck, I want to correct that the eyeballs don't actually recede into the orbit. The fat deposition changes and it makes them appear to be more receded. But the other is true, that our corneas are lackluster, pupils are smaller, fundoscopic exams more difficult, and dry eyes is a very common complaint. Presbyopia occurs in nearly everybody by age 50. By 70, the visual acuity really declines, but still elderly adults maintain about 20/20 to 20/70. Presbyopia really is a progressive loss of accommodation and the ability to focus on nearby objects, and that's coming from the lens. You know, we have more of a issues as we age with cataracts, glaucoma, and macular degeneration. The head and the neck also include acuity of hearing diminishes, called presbycusis. That's when the elderly fail to catch those upper tones while they can hear the lower ones, causing words to sound distorted. They have less salivation, decreased sense of taste, and medication disease can cause these, but they can also just occur from normal aging. The thorax and lungs, they do lose capacity for movement and just expansion because of stiffening. Even the dorsal curve from skeletal changes might produce some kyphosis, which rounds the chest. However, we still see in elderly that they maintain a pulse ox of over 90% typically. Cardiovascular wise, it behooves us to understand this process of aging. Systolic bruits are heard in the middle or upper portions of the carotid arteries do suggest a partial arterial obstruction from atherosclerosis. Well, if they have obstruction in the carotid arteries, they probably have obstruction in the coronary arteries. Extra heart sounds after age 40. S3 strongly suggests congestive heart failure. S4 can be considered healthy in older adults, but it does suggest decreased ventricular compliance and impaired ventricular filling. Cardiac murmurs. Systolic aortic murmurs are common. They are detected in about a third of people by age 60 and half of those over 85. And that's all with the fibrotic changes that thicken the bases of the aortic cusp. The calcification follows, resulting in audible vibration. So in most older adult, that process of fibrosis and calcification is known as aortic sclerosis, but it doesn't impede blood flow. In some, the aortic valve leaflets become calcified and immobile, resulting in aortic stenosis and outflow obstruction. One way to discriminate is a brisk cardiac upstroke can distinguish aortic sclerosis from stenosis, which is delayed cardiac upstroke, but clinically distinguishing them is difficult often. Just remember, similar changes can occur in the mitral valve, but that's usually 10 years later. I will go back just to mention that the peripheral arteries tend to lengthen, to twist, to become more harder and less resilient, and there's increased arterial stiffness and decreased endothelial function. Loss of atrial pulsation is not typical, and it demands careful evaluation. I'm sorry, let me go back. Breast and axilla. I think granular tissue atrophies is replaced by fat. So the breasts are smaller, they're softer, and they hang pendulous. Abdomen, interesting. Fat tends to accumulate in the lower abdomen and near the hips, although your weight might remain stable, but you kind of change where your fat's distributed. In abdominal disease, remember it's often blunted in the older adult. Less pain, and fever is either absent or very marginally elevated. Male genitalia, the penis gets smaller, the testicles descend further into the scrotal sac. About half of males have erectile dysfunction. Number one cause, vascular in nature, although we can associate erectile dysfunction with chronic disease such as diabetes, hypertension, dyslipidemia, smoking, and med side effects. I remember a professor told me when I was in my graduate class that erectile dysfunction issues can occur about a year or two before coronary symptomology. So let that be in your toolbox. Female genitalia, this is all about cessation of menstruation between 48 and 55. Often women experience hot flashes for the first 5 years. They might have and probably will have vaginal dryness, urge incontinence, or dyspareunia. And in about 10 years, the ovaries are no longer palpable. They're too small. Prostate. Proliferation of the prostate epithelial and stromal tissue, known as benign prostatic hyperplasia. It starts in the third decade, but it continues until about the seventh decade. Only about half of men have BPH symptoms, so recognizing those and being able to treat those. Peripheral vascular, aging itself conveys very little clinically important changes in the peripheral vascular system. Musculoskeletal. In the musculoskeletal system, we do see significant shortening, and that's occurring as a person ages and loss of height as the trunk and the intervertebral discs become thinner, and the vertebral bodies shorten and collapse for osteoporosis. Skeletal muscle decrease in bulk and power, and range of motion diminishes in osteoarthritis. There's about 30 to 50% decline expected in that bulk and power. And sarcopenia means loss of lean body mass and strength with aging. Nervous system, this is interesting. Aging may affect all aspects of the nervous system, from mental status to motor and sensory function and reflexes. Most elderly people do well on the mental status exam, but selective impairments become evident, like benign forgetfulness, causes difficulty in recalling names, objects, certain details. So sometimes it's difficult to distinguish changes from normal aging from age-related or disease. I do want to give you a pearl. Number one reason for memory loss in elderly, vitamin B12 deficiency. Please do not forget to include that in a memory workup. of the elderly, or hey, perhaps just in when you're screening your elderly. Thank you.